Good afternoon. I'm Lance Manning. I'm a surgeon and a teacher and a father and a spouse and a business owner and entrepreneur and wear a lot of hats like all of you do. And I think a lot of physicians would agree with this, that it's becoming more and more difficult to wear that hat as a physician. Not just from a practice standpoint. I mean, it's difficult telling a patient that you've cared for a long time that their cancer treatment didn't work. Or telling parents, like I had to do last week, that their child has cancer. But there are a lot of other problems in medicine, and a lot of those have nothing to do with the direct patient-physician interaction. We've heard these for the last 2 days. There are a lot of physicians that feel they don't have the time to see the patients they're required to see. There are a lot of problems with physician attrition and nurse attrition. You don't know from year to year if there are going to be significant cuts in federal reimbursement that are going to limit your ability to maintain your business and continue to supply the care that you need to for your patients. And this leads to some physicians being burned out, quite a few, unfortunately, and it leads to conflict, and it leads to poor communication and loss of empathy. It leads to medical errors. And the people left holding the bag are the patients. And they understandably become depersonalized and disconnected and dissatisfied. But the good news is it doesn't have to be that way. After being in practice for some time, what I've learned is if I take it back to the very specific point of doctor-patient interaction at the bedside, then the other things really don't matter. If I rate my success by the patient happiness and their satisfaction, then a lot of those things outside the room, they really don't matter at all. It's a really good job when your patients and the people you deal with every day come in and tell you how happy they are that you just listened. You can do a lot of healing without necessarily healing cancer, and a big part of my practice is that I deal with a lot of head and neck cancer, thyroid cancer, cancer reconstruction. So that's the topic of this talk today. How do we do it? Emotional intelligence is not a new concept. There was a paper written by Peter Salovey from Yale and Jack Meyer from the University of New Hampshire back in 1990. And what they presented was that our conventional measures of intelligence were inadequate. They measured intelligence related to feelings. And what they found were a couple of really important things. One was that it was measurable. And two, that it was learnable, unlike traditional IQ. This was popularized by a book that probably several of you have read by Daniel Goleman about emotional intelligence, and he made a case for some crucial skills that showed that self-awareness and self-regulation and empathy and motivation and social skills can determine our success in work and in our relationships and in our physical well-being. And then there's been a lot of neurobiological data and work that's been done since that time. In fact, Dan Siegel yesterday talked about a lot of his work that they've done at UCLA regarding that. And there's been work done all over the world, fortunately. There's been a lot of application of these concepts in other industries, unfortunately, as of yet, not as well in the medical field. There's some examples. A lot of models, some are behavioral-based. Some are trait-based, some are competency-based, and some are ability-based, just like traditional IQ testing. What's come out of this has been a global partnership of developers and researchers and practitioners in primarily the fields of business and leadership development and secondary education. And here are a few examples in the business world. When PepsiCo integrated EQ training, they had significant increases in profitability. In fact, it added about $3.75 million in economic value, which was 1,000% return on their investment. At Motorola, when they instituted EQ training, 93% of their employees had an increase in productivity. The Air Force used this in selection of their parajumper special forces. And what they found is if they used EQ testing in the selection of these folks, that they were much more successful in getting the candidates through their training, and it was only a $10,000 investment, and they saved $2.7 million. And this goes beyond the bottom line and beyond dollars. There was a pretty good study, actually, of retiring NFL players, and what they found was that 60% of the life success factors can be predicted by their emotional quotient. A lot of industry experience with teamwork and leadership success and performance and job satisfaction and stress relief and innovation, commitment, customer service, and all the things that industry tends to do a whole lot better than medicine sometimes. Been a lot of experience in secondary education, as I mentioned. There is widespread experience that shows increase in academic performance, and these children are much more likely to not participate in high-risk behaviors. They're more likely to stay in school. And this equated actually to measures of improved health and happiness and success later in life as they followed these in some longer longitudinal studies. Well, in traditional, historical medical education and practice, we haven't really focused on this. And there's starting to be some increase in some small parts of medical education for the current students coming through. But this hasn't been a focus historically. And a lot of people out in practice have no awareness that this exists even, and have no training. And what we focused on in the past have been primarily technical skills, academic prowess, focused on how well they do in their organic chemistry or in their calculus courses. There really has not been a good assessment of how to rate these prospective medical students, these prospective residents, prospective partners in practice with respect to one of the things that's actually crucial to their practice and making their patients happy. So that being the case, we put together a case study. And we took and put these EQ skills into medical practice. And what we found was an implementation in our clinic that there was zero nursing turnover in the pod where we implemented it. For comparison, in the previous 18 months in the same pod, there had been a turnover of multiple nursing jobs. When we compared that to the pod down the hall, it's very similar. It's in the same clinic. Similar practitioners, that there was turnover of 5 different nurses during that same 18-month period. At the end of the case study, we found improved staff and nurse satisfaction and a lot fewer physician complaints. We also had some unintended results. When we looked at productivity, at 6 months, actually clinical productivity shown here increased about 10%. At 18 months, it was 32%. That's big-time institutional change. Then we looked at revenue. We didn't intend this to affect revenue, but these are pretty dramatic results. 23% at 6 months and 34% at 18 months. Now, a medical practice is dynamic as any business. It's hard to account for all factors. But I can say this, that all of the physicians involved were all at the partner level, had all been in practice for multiple years. The practice was established. There were no new providers in the same specialty that either came or left during that same period. There was no change in the billing practices, no change in the billing management, no change in the fee schedules, no change in the involvement in the PHOs, and no new service lines or additional satellite clinics. So while we didn't account for a lot, we did account for what we could. So based on this wide industry experience, the obvious need in medicine, and also our own anecdotal experience, what we did is we created a partnership between physician and patient. And what we set out to do was to define and create and promote tools for the betterment of the patient-physician interaction right here. And there's some science behind that in other fields. And we set out to reapply that to medicine. This was created from the start between myself and actually a former patient and friend and serial entrepreneur and technologist, Mark McQueen. Shout out to Mark. So, created a model, and we created a panel of expert end users We've engaged existing EQ organizations, taking some validated tools from those other industries, reapplying those in conjunction with our own developing assessments and tools, and create this model, which it's not complex, but it makes a lot of sense. And basically, it's what we've all been saying. We all know, there are multiple players in the room. But to define those in particular so that you can teach specific traits is what we set out to do. So obviously you have the patient, you have the caregiver, which can actually supplant the patient sometimes if you deal with people that are either pediatric patients, or you're dealing with people that are either demented or their caregivers are sort of their surrogate. And then obviously the physician, and then this milieu, the environment. And there are intrinsic and extrinsic components of both of those. For example, the intrinsic environment for the physician or the patient, you've got the self-awareness, it's reliability, being centered, where extrinsic would be more like how you're displaying your body language, your tone of voice, your micro-expressions, etc. And there are a number of different things. I'm not going into the details. Examples of the intrinsic and extrinsic environment for the sort of general milieu would be, the intrinsic environment would be when you're in the clinical room, what do you see? What can you hear outside the door? Are you comfortable? How's everything positioned, etc.? And then outside of that environment, there are a lot of other factors that obviously impact the way that the patient perceives this interaction, and they're both culturally, or they're culturally based. Obviously, they have to do with the patient's own financial state, where the patient should be at that time, what's going on with the patient's family, the support system, and there's a big list, and you all are very aware of those things. And then our assessment from this panel of end users, and also the experience in other industries, and using their constructs and models that have shown to be reliable. Want to establish benchmarks and have an outside agency take and validate and perform as analytical studies. Make sure that what we're doing is reliable. We're using social media. I'll explain to you how. To a lot of physicians, especially older physicians, I think it's a surprise how many patients use social media to find them or to rate them. And there are a number of studies here that show basically about half of internet users have used or say they will use this to get some information about their doctors. About 70% of those people will make healthcare decisions on who's going to treat them and where based on that information. Well, we looked at those rating sites and we compared them to EQ concepts. And what we found was that about 70% of what a physician is rated on, of the questions asked of the reviewers, is directly impacted by their EQ. So, putting this together, we're using the social media not only as an example of an application, a necessity, but going out and using these rating sites and reviewers to take and to identify high EQ physicians. There's some people out there that have got it right, even if they don't know why they've got it right. Going to use these high EQ physicians to further define that model. We want to take this model and further define the direct patient-physician encounter face-to-face. We want to make that better. I've heard of standardized patients with a standardized physician, and not that everyone has to read off a script by any means, but at least if you can take some of those skills that are well known in sales and in customer service and in a variety of industries and apply them on a step-by-step basis. It's more than making eye contact. It's knowing what's going on inside you, inside the patient, putting that together, what you're seeing on the outside, and providing the best care, in the context of what the patient expects. With this evolving model, we want to promote and partner to create some platforms to take and teach these skills. And I think a lot of people up here and elsewhere are taking and doing some great things, and hopefully we'll be able to collaborate on a lot of these things to create the platforms to put these skills into place. And then we want to take and put these in a context to where they can be assessed. And I guess our vision from this would be, at some point, when you go to apply to medical school or residency, you not only take an MCAT, you take an EQ equivalent. And when you get to a certain base level of intelligence, of traditional intelligence, beyond that, and once you have those basic skills to be able to interpret the information, to get that, do all the things that are necessary from a traditional academic standpoint, they don't really determine success. When you're in a job that deals with people and customer service, obviously, you need to take and have a different subset of skills. And I think at this time, our education is heavily, heavily weighted toward the traditional IQ skills, the traditional academic skills. And there are a lot of other untapped skills that can make patients feel a whole lot better. You know, what I found in my own practice is if I take and reach out to the patient and do all the things we talked about and understand what their expectation of me is, what I can do to help them, it's a whole lot easier. You know, not everyone has the same expectation. Not everyone wants their problem fixed the same way. A lot of people, they just want someone to hear their story. They want to know that you're engaged. They want to know that you care. So, in summary, we're trying to increase awareness of emotional intelligence in a medical setting. We want to take and create some tools that are very specific to that physician-patient interaction. Want to show the relevance in a patient context. And we want to take and collaborate, provide a platform to teach these skills. In the words of Teddy Roosevelt, they don't care what you know until they know that you care. There are a lot of people here that care. I think what we're trying to do is just find a better way to show that. So,
thank you very much, Dr. Manning. We'll have a brief time for questions. I've got them. I'm, very interested in medicine and technology, and medicine and the patient aspect. That's sort of what I've built my entire practice on. I was just wondering, in terms of the push and pull behind the emotional quotient, do you think that there's any effect in any positive benchmarks or effects that you have just by talking about it? That is to say, even just broaching the subject, does that somehow give you credibility in the eyes of your staff, in the eyes of your patients, in the eyes of...
It does, and actually beyond that, there's been some good literature that shows when you talk about feelings, you address it, and you empathize and you express that, or even with yourself, that a lot of the physiological effects that occur with anger, for example, if it's like, I'm really mad, then when they've measured those physiological effects, they're toned down. So it's the same way when I would engage you and say, yeah, I understand, you're nervous. Well, when you acknowledge that, it tends to pacify the situation. So that's been shown physiologically in a number of studies, again, in other sectors, but yeah.
Thank you. Sorry.
Hi, thank you for your presentation. I think it's really great what you're doing. I was just wondering whether you had any perspective on med school admissions and how they view technologies like digital health technologies and people who have worked in that space, and just how you think it's changing, or whether that's even something that they consider today.
There are probably people that are a little closer to medical school admissions than I am right now, and maybe actually to address that better. In looking at some of the admission requirements lately, I think that we're really in a transition phase. One, prerequisites for a lot of medical schools are changing. And I think some of the medical schools, they're requiring things that are more humanities-based. I think as far as digitizing that, obviously that's great because it brings so much information to you and to the patient. I think that we have to be really careful with it, as the speakers before me have noted, to not make that a barrier. And I can tell you how we do it in our practice, but as far as a medical education, I think that in the future, because of the awareness, because of what we're coining emotional intelligence, and it has been coined, and other people are calling their soft skills, or whatever their patient physician training is. I think that as it becomes more prevalent in medical education, the prerequisites for that and the training for that in advance are going to be much more available and much more required.